There you
Okay.
go, Chair. It's live on YouTube.
Thank you. I think we're now live. Welcome to the new year. I don't know whether it's a good new year or just a satisfactory new year, but I hope we're all well. We just moving on with the agenda straight away into the board meeting. We have apologies from Councillor Roach and Dr. Da Costa.
Dr. Lee Hunt's just sent his apologies, Richard.
Okay. Dr. Hunt. We are quorate. Are there any additional declarations of interest on any specific agenda items today? No. Okay, well, just move on with got a couple of short clips about patient stories just to start the meeting and set the start of the meeting. Gordon, you're going to play those, I think. You're on mute, Gordon.
All right, sorry, I just said I'll just share my screen. Hopefully I'll all go to plan. Can people see that my screen? Sorry, I'll take my emails off. So yeah, you see the CCG site at the moment. Sorry, I'm just trying to get the. So we'll do the first COVID vaccine first. Is that all right, Chair?
Like a good idea.
So I'll play that one, and then I've got the other one ready after this. So I'll play that now.
It's fantastic news that the COVID vaccination is here and in Rotherham. As a local GP, I'm really proud of all the effort that's gone on to get us to this place. It was great to welcome Mr. Drury-Smith this morning to be the first community vaccination in Rotherham. Such a lovely gentleman. And lastly, all patients eligible will be called for the COVID vaccination as it becomes available. There's no need to call in.
I'm certainly very grateful to be having this vaccine, and I hope it'll be available to everybody in the country soon, and that I would advise them not to refuse having the vaccine. And because without a doubt, I think it's something that will save people's lives. And if you don't mind me backtracking about 90 years, when I was 4, in Sheffield, there was a bad epidemic of diphtheria. And the isolation hospital was full, and the doctor that we had then, he treated me at home, and he was certain it was the diphtheria that I'd got, and he went and got the vaccine then, and I remember my mother holding my arms down and my legs, and he injected the vaccine into my side. And I'm absolutely certain that saved my life and the lives of many others. So it's most important that when these vaccines are available for these different viruses and that people don't refuse them, because it's certainly for their own good, and I'm certain that it will save their lives as well as it has done in mine over the years.
So that's the first one, Chair. I don't know if you want to get comments first before we share the next one.
I think we'll save comments about the vaccination till Ian can give us the vaccination update, because it's even more good, relatively good news when Ian updates us as well. So we'll
just go on straight onto the second video then, Chair. Yeah.
Yeah, please.
Hi, how are you? Hey, got it.
There we go.
The residents have been connecting with their families, which has been invaluable.
Oh, I love to keep an eye on social media. Googling.
Video calling my dogs.
They are somebody's husband, somebody's wife, somebody's father.
Being able to connect to their loved ones has been a real lifeline.
Okay, thank you, Gordon.
Yeah, good, Chair.
Okay, just a couple of things there about what's happening. I think we've had a very successful rollout of a lot of the digital stuff into care homes and everything to allow people to stay in touch as well locally. Ruth, are there any other patient or public questions from the agenda? Okay. In which case, moving back to the next item on the agenda, the minutes from the last meeting from the 2nd of December. We'll move through for accuracy any matters arriving that aren't on the agenda or in the action log. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and 30. Okay, we'll take those as an accurate record. Thank you very much, Lindsay. Action log. We have one green completed, and one that's still in development and come back.
Well, what I was going to say, Richard, if it's okay, on the one that's amber, I was going to propose that I take that off, because what that was doing was coming up with an organisational development plan for the CCG, where I think we're into a different phase now, where we'll want an organisational development plan to form the next organisation, won't we? So when we agreed this one, this is going back 6-8 months, when it was talking about how all the CCG emerged from COVID and, you know, how come up with a 5-year OD plan. So the spirit of the actions passed by as integrating care's come out. So would it be okay with the governing body members to drop that as an action? I'm recognising there'll be a piece of OD work to form integrating care, our bright and new future.
I don't see any disagreement, Chris, so yes, we'll take it off.
Okay. Thank you.
Okay, then moving on then to Chief Officer's report. It's a bit sparse, but that's because...
Well, I was going to ask, Chair, with your permission, I would like to give a verbal update on COVID, but I would like Ian to go first to give a high-level update on vaccinations, if that's okay, because that's obviously the most important thing. So if we do a quick verbal on vaccinations, a quick verbal on COVID, then I'll cover off the report, Chair. Would that be okay? That's
absolutely fantastic, because things move so quickly and the amount of hard work and so speedy work that's happened in the last 6 weeks.
So I don't want to steal Ian's thunder. So Ian, do you want to do vaccinations?
Ian.
Yeah, thanks, Chris. Thanks, Chair. So Happy New Year to everybody. Just in terms of the update where we are from the last time we got together 4 or 5 weeks ago, it was an interesting reflection on the gentleman in the video there, because that was a chap that was vaccinated middle of December, and you just kind of think what we've done over that period since the first site went live. So we've now got our infrastructure bedding down quite nicely to deliver the vaccination programme across Rotherham. What that looks like, it looks like 5 sites out in communities being delivered by our primary care leaders and primary care colleagues of nurses, GPs, supported significantly by our volunteer network. And on the whole, I think we reflect that it's gone positively in terms of that rollout of our community settings. Within that, then, we've also got our hospital colleagues that have also delivered a hospital hub. So that went live last Monday. And that in the main at the moment is vaccinating hospital frontline and community frontline staff in the Rotherham place. And we'll extend out to vaccinate further staff cohorts as we plan those over the coming weeks. In terms of our other bit of estate that we've put in place, we have put a call centre in place in Rotherham. What that does, that will allow us to make direct contact with patients now, to book them into their appointments going forward. The first 2 or 3 weeks of our scheme, practices were doing that But as we've kind of caught ourselves up, we've taken a Rotherham Place approach, with the exception of Rother Valley South, to have that call centre, just to release the burden on primary care with the sheer volume of calls that will need to be made to book patients inappropriately. So that describes our infrastructure, Chair. In terms of vaccine supply, there's quite a lot of information out there in terms of vaccine. In the prominent vaccine that's come into Rotherham over the last 4 weeks has been the Pfizer vaccine. We've now started in this last week to start and see we call it the AZ AstraZeneca Oxford vaccine starting to come through. And that gives us a real good opportunity now to expand our scheme at pace into our care homes, to vaccinate care homes and residents in care homes. I'll talk about the cohorts in a second. The final bit of our infrastructure that links to that is housebound patients. So now we've got the AstraZeneca vaccine into the Rotherham Place. We can now deliver into housebound patients, and our community nurses are stepping up into that role to really support us do that, working jointly with our local vaccination centres. In terms of coming back to the cohorts, in terms of who we're targeting in this next period up to the 15th of February, which is the government ask, is that we look to get a first dose vaccine into all our health and care workforce. That's not just frontline, that's the wider health and care workforce. We need to be getting the vaccine out to between the 70s and up. So we start at the 80 plus, we'll then go to 75s and 70s, and we're well into getting into most of the 80s now. And then we need to really be targeting in on the clinically extremely vulnerable, which we recognise in our areas, those patients that we're shielding throughout the COVID period, and we're putting in processes now to appoint those over the coming weeks, all with a view that we get that cohort through with first dose by the 15th of February. So subject to vaccine supply, we are confident that we can deliver on those targets. And again, I've described that we've had a good start to the programme, Chair, but lots of work still to do, and it's a long road ahead of us. This is not a 2 or 3 week programme, probably more like a 6-month programme for us. Okay, I'll pause there and take any comments or questions. Mindful that at the moment there's not a lot of information in the public domain with regards to data and numbers of vaccines that we've undertaken. Thank you.
Okay.
I'll just wait and see if there's any questions there, shall I, Chair, and before I do the next bit.
Lots of questions. Debbie, then Janet.
Sorry, Chair, thank you. It's not really a question, it's a comment, and I'd just like to endorse everything that Ian's been saying with regards to rolling out the vaccination, and thank everybody that's involved. But I spoke yesterday at Primary Care Committee, and I'd like to share with governors here today that the volunteer across the patch is being organised through Helen Wyatt, our patient engagement officer, and I'd just like to share some statistics because I think they are remarkable. It follows on from the the volunteer support programme that we did for the flu vaccination. But as of well, she updated me again this morning, so it's a little bit higher than it was yesterday. But we have got 182 fully signed up volunteers across Rotherham now. They're working across the 5 different vaccination sites. Yesterday, at the end of last week, they had actually supported, there were 180 volunteer slots for vaccination periods of time at those vaccination sites. Then 180 volunteer slots were filled. And then this week it was 130, but that was like Monday, Tuesday. So I'd just like to thank the public really for getting behind us. And as we spoke at Primary Care Committee, it's such a positive, collaborative system at the moment across every partner that's involved in this, including our volunteers. Not all of them have come from the patient and public network groups that we have, but it's just brilliant. It's absolutely fantastic. So I just want to share that with all governors. Thank you.
Yeah, it's an amazing. I think we're all pulling together. We'll get this delivered really quickly.
Yeah, definitely.
We'll keep. Janice.
Thanks, Chair. Well, Debbie said it about the volunteers and the team effort and that, and just to endorse that. Just to update you, at Primary Care Committee yesterday, we received a paper for information and a verbal update on freeing up GP practices around the vaccine programme, and it's just to update governing body members that the information was discussed with the local medical council and the CCG, and we've put in place the appropriate decisions in order to action this work. Can I just ask a question as well? Sorry, it's just about take up. and I'm assuming that the take-up is high. I hope the take-up is high. And also take-up amongst not just over 80s, but also staff and appropriate health and care. Is that take-up high as well?
Yeah, thanks, Janet. I'm not in a position to share information in the public in terms of numbers. What I can share, though, is a view with regards to our observation of DNA or do not attend rates, and they are very low, is what I'd say. I think what we're finding is that although we've put a lot of time into our planning for location of sites, and we had a principle of a 10-minute car journey wherever possible to get to our sites, to just kind of will people travel, etc. We are in most of our areas being able to give choice as to which site they may like to go to. And people are travelling and they are getting into our centres, so we're having a real low DNA do not attend rate, which is really positive for us. So those that have been offered appointments are taking them, and then they are subsequently coming through, which is good.
Thank you.
In terms of staff, Jenna, I don't have specifics on staff. I can only describe from what I've observed in these centres, and also talking to primary care colleagues and people on the front line. And it's probably a similar view. It does appear that people are taking them up, but again, I don't have figures yet. They're not in the public domain for us to share.
Thank you.
Okay, Jeff, then Simon.
Yes, a few things. I think it seemed a long dark year and a long dark winter, isn't it? It just seems as though until recently figures were getting worse and worse, and yesterday there might be 3 figures. One of them's slightly better, the other's going worse. The flu vaccine numbers starting to come at 2.5 million is the new thing, and that changing. I think 100% recognising sort of support from other people, again, from governing body, CCG, the work that Ian, Sue, Joe, everyone at the CCG has put in. There's been a massive amount, and the ops group have put a massive amount of work into this. Everything's had to be thought through to the nth degree. And in theory, if things work and plan properly, it sort of runs smoothly. So we've had to overthink everything, but effectively get people in vaccinating, sitting them down. As long as we're doing that, the most important people with that are the nurses, in terms of the fact that they were the ones doing the jabs. But I'd agree definitely with sort of other people saying the support from the volunteers is what makes this flow. It's the flow that's the issue, getting people in, getting them through, getting them knowing where they're going. And without the support of the volunteers, the service would be a shadow of itself as far as that. I do feel this is the start of some good news. We can't quite say that it is sort of fully yet. I've just come from one of the clinics and I was there on Saturday, but there's a buzz in the room. You can feel an energy. No one's like, everyone's, I think, felt sort of in lots of sense socially and work-wise a bit battered down, but when you sort of come out of that room, there is like a feeling of some positivity, which has just not been in life in lots of streams before as far as that. If you'd asked me Friday from our PCM, there was an awful lot that we've not done, as far as like Ian's saying with these groups. We've done a session Saturday, Sunday, but we've in our surgery, I think as of Sunday, almost all the staff in sort of 3 of the practices we've done. We'd supported some of the hospice staff, we supported some of the federation staff. There's vaccines going out to surgeries. One of our largest nursing homes in our PCM was vaccinated today. There's one of the next ones tomorrow. We're getting the Oxford vaccine through. As far as the vulnerable, most of the over 80s have been in. So yeah, as of Friday, to say of those like risk groups, it wasn't particularly looking sort of that rosy, but actually if you put that on at the end of this week, I think there's been a massive amount of traction that we're starting to get with that. DNA rates at our clinic on Saturday morning, potentially 250 odd people sort of there. There was one DNA that turned out there was a bloke that was in hospital, so he couldn't have been there. So people are turning up and they are coming as far as that. And it doesn't quite feel like a good news story yet, but I think when the weather's getting better, it's a bit lighter nights, when hopefully we see the peaks of those numbers starting to drop over the next few weeks, and then when the numbers of people vaccinated are hitting like 5 and 10 million, I think we can all start feeling some more degree of positivity. We're not out of the depth still in any sense, as Ian says. If we're looking at sort of the adults with this, it's December that we're sort of finishing off the vaccine. But it's that sort of direction we all feel we're sort of moving, and that we can feel as though we're actually sort of going to start getting somewhere hopefully soon. Maybe I'm being, no one can predict anything with this COVID thing, can we? But I'm positive that you know, this is the beginnings of actually starting to get somewhere with this.
Okay, thanks, Jeff. Simon?
Yes, I was going to say many of the same things as Jeff, really. Definitely, it's a very positive thing seeing the people coming in and going out, and there's a lot of putting together with that. It's a real sort of community spirit when you feel that, and as we were saying earlier, the volunteers are vital for that, and it's done an amazing job. I think there's certain things I said before there's some lead people in each practice and PCN who are taking a lot of the heavy lifting for this, and I think the sooner we get it into a bit more of a business as usual type of thing for the next few months, the better, because I think there's a lot of stress on those clinicians and managers, as there is people within the CCG, and it's looking after them is an important thing to consider. Just applying to one of the things about staff, most staff are very happy to get that, but there is still some disinformation out there, particularly the youngest members of my staff have been looking at some of the more wilder things on the internet about whether you should have the vaccine or not. So there might be some work to do there with just making sure that we get the proper health messages out. There's a few young women in our practice who are concerned about fertility issues and things like that, which have gone across social media. So that might be something to consider. But so far we're getting very good uptake overall.
Okay, shall I move on to a COVID update, Chair?
Yep.
So just to finish off the vaccination piece, I think we ought to put on record our thanks to the nurses, obviously with the GP, working in partnership with the GPs, but we all know the nurses do all the real work, don't we, GPs, in terms of vaccinations. Catherine, I said it for Sue. Can you report back that, please? But no, on a serious note, it's everybody in primary care, isn't it? It's the reception staff, it's the practice managers, it's everyone who comes together. Special thanks to many CCG staff who've been going above and beyond as well as part of the process. But the final thanks that we just ought to acknowledge is because we've had a conflicting advice from our national leaders. Our patients have been very patient with us as we've arranged, sometimes cancelled, but then rearranged patients. Everyone will get their vaccination, but we do recognise that patients have been patient with us. So just a big thank you to everybody on behalf of that. And obviously don't forget the volunteers as well. In terms of the wider COVID picture, it's not quite as rosy, I'm afraid. So infection rates in Rotherham are probably around 300 per 100,000. So in context, that is extremely high for Rotherham, but the national average is running about 630. So we are actually in the bottom 25% in terms of infection rates, but that doesn't mean that they're low. It means they're less high. So it is extremely pressurised in terms of the system. In terms of Rotherham Hospital, we've got roughly around 120 patients. You think a 400 bed hospital, about 120 COVID patients. It is struggling. We're in the height of winter. This is absolutely the busiest time of the year in the NHS in any normal year. So to have 120 COVID patients on top of that, and it means everything in terms of social care, discharge, everything needs absolutely extra effort to make sure the whole system flows. So there's some real good system working across health and social care to make sure we keep the flow through our hospitals to manage. The trend is promising. So the trend in terms of infection seems to be levelling off at 300, and also the hospital, the numbers of patients in hospital does tend to be settling around the 120 level. So that is a positive. The public health experts are advising us that until we get to the very low numbers, it's likely to take until April though, even with the effect of the lockdown. So we are heading for a very difficult few months. And obviously the key concern for us is our staff absences and staff, having the resilience to get through the length of period we're going to go through. So the hope is the effect of the vaccine will start to be seen in March or April, because even though we're vaccinating now, it takes 2 or 3 weeks for the antibodies to have an effect. And obviously COVID infections take a couple of weeks to have an effect. So we'd expect the vaccine to start to see an improvement in March, April. And obviously as the lockdown should have an effect then, and also the better weather. So the hope is that's when we should see things improve. But it is difficult. The final thing just to mention is Obviously, we are a whole NHS as in England as a country. London and the South East are under extreme pressure. In terms of critical care patients, there's a very likely scenario that we will have to do mutual assistance in the North and the Midlands to help out in relation to critical care. So that's something we're modelling now, is to see as a system how we can help our partner areas, particularly to London and to the south of us. That isn't happening yet, particularly in any larger numbers, but it's something we're having to plan for and to model for. So I'll just see if there's any questions on that, Richard, before I move on to do the rest.
Okay, questions for Chris? Don't keep going then.
Sorry, I'll keep going then. Sorry to lower the mood. So in terms of the Chief Officer's report, the integrating care paper was the key thing in the report. The integrating care agenda, it has been put on the back burner for a few weeks as COVID obviously is our key focus. So we were asked to come up with a plan for April for how 2021 will work, 21-22 will work, and then a further plan for September. It is likely we may see a month or two slippage in those deadlines. So we'll keep updated on that, but there is no updates because all the meetings relating the discussions on that haven't been happening due to the COVID situation. So we'll keep it on as a standard item on our agendas to keep updating members on, but as it stands, the document is as we are, and the consultation, so the engagement process finished last week. I'm just having IT problems, so I can't see the rest of the report currently, Chair, but if there's anything on the report anyone wants to ask any other questions on, please feel free.
Chris, that was it.
Is it? Okay.
Okay, any questions on that for Chris? Okay, moving on then. Strategic updates, Chris, it's you again. Chief Officer's report for the SYB ICS.
Yeah, okay, I'm back on now. Just had an IT failure. So in terms of this report, what we do is I bring it here as for information, really. So I wasn't intending to go through the report. It's not something I've written, but it's here for transparency and for information. So if anyone does have any questions, I'll be more than happy to take them.
Any questions for Chris? Oh, okay, moving on then. Finance and contracting performance report, Wendy.
Thanks, Chair. Good afternoon, everyone. So we've got month 8 report today, so at the end of November. So starting at the top of the report, we've got cash and payments still being well managed. The tables at section 2 and 3 can demonstrate this for you, and it shows 100% achievement against the national payment requirements. So moving on to section 5 and the OCS. Last month, we discussed the reported position being clouded somewhat by 3 things. There was the issue of outstanding allocations linked to the additional roles and some other primary care allocations. Then there was a second item of a pending retrospective allocation adjustment related to the month 6 COVID claims. And then the third thing was a pending retrospective allocation adjustment linked to the hospital discharge programme. So for those 3 things, for this month, the first one with additional roles, we will only get reimbursed that as we spend that money. So that's net neutral to us at the moment, but we have now received the other primary care allocations that we expected. We have since received the month 6 COVID allocation. And while we're yet to receive the hospital discharge programme funding, and it's now clear that we're unlikely to do so before month 10, what we've done is we're now reflecting the expectation of that funding in the OCS report. So looking at the bottom line in terms of what this all means, if we go to the bottom line on our OCS and we start in the light blue columns, then we've got a bottom line reported year-to-date overspend initially of 2.2 million, if everyone can see that, but then we've got an adjusted position 2 columns later of 0. So that's showing how when we get that hospital discharge programme funding coming in, we are net neutral and we are still online to achieve our plan. And similarly for the forecast outturn position of 2.9, again, adjusted for the expected allocations, we're online. So this is really good news for us. So we are still online to achieve our plan. That forecast outturn is still subject to a number of risks that I've set out at section 12. And I just want to flag with governing body that there's a strong potential for the forecast outturn to further improve. And that would be on the basis predominantly of the growth in prescribing coming in now at lower than we predicted for the second half of the year. You'll recall that prescribing data is always 2 months behind, so we have this position to manage, but we are now starting to see a steadily lower cost growth than we had anticipated. So how I've reflected this so far is that if you look in the year-to-date line on prescribing, we are declaring now an underspend on that line, but we're keeping that in reserve just in case, because there's lots of discussions going behind the scenes. So we flagged the potential for an improved position with the ICS. However, we need to balance that currently, and this is one of the risks, with NHSE indicating that they will continue to review spend in year and they reserve the right to revisit the COVID allocation adjustments, the retrospective adjustments that were made to us in month 1 to 6. So by the time we get to next month's report, we'll have further clarity on that, because there's lots of questions now up the chute with NHSE to discuss with them around how we should report for that eventuality. So at this stage, I'm just going to ask governing body to note that that update and the more detailed narrative in the report, and I will open up to any questions, Chair. Thank you.
Okay, thank you, Wendy. Questions, John?
It's not really a question, Chairman, really, but it's just really to feedback some of the discussions that we had at our Aqua Committee last week, where we actually took quite a lot of assurance and even confidence about this year's financial plan. As Wendy's described, it feels like the income we've been assuming is coming in as Wendy anticipated. The risks are abating somewhat, and then new opportunities are coming along as well. So the feedback from Aqua really is that there's a certain level of confidence that we will achieve our financial forecast this year, as Wendy's described.
Okay, thank you, John. Jeff?
Yeah, just a comment as well, really. Stuart Lakin was at primary care yesterday with some other people, and I feel prescribing and finance is a bit like being a 1950s weatherman trying to predict the weather when you look at what facts and figures and things we can sort of work with sort of now, isn't it? It's just such a complex, complicated sort of year as trying to get your head around. But it seems as though we're sort of moving in the right direction, at least with this. But there are so many sort of variables and factors that sort of have chopped and changed over time. But at least feels as though we're sort of in the right direction, aren't we?
It does, Jeff. Yeah. Long may it continue.
All these conversations, this one included, but also the vaccination, I come back to Winston Churchill about this may not be the beginning of the end, but it's certainly the end of the beginning. There are things you begin to see in all aspects of this that are little green shoots.
Yeah, agree.
Okay, any more questions for Wendy? We'll look. We'll probably bring ourselves back down again with the delivery dashboard then in.
Chair. So yeah, it's the routine delivery dashboard, and it follows a bit of a theme, doesn't it, over the last 3 or 4 months and beyond in terms of some of the challenges on system performance. And just to remind colleagues, we're looking at, in the main, November, December periods of time on this reporting view. And again, there are some challenges in there that we can't walk away from, and that we'll need to really plan for when we come out, hopefully, of this next wave of COVID, to get our system recovered to the expectation on delivery going forward. And what I would say, particularly on the hospital-based stuff, is that when Chris was talking earlier in the dialogue around the pressures in other parts of the country currently, just to remind colleagues that as we went through the October and November period, our hospital was at one point had 170 COVID patients in it as it ran into Christmas, and then it's currently at that figure between 110 and 120 at the moment, but that impacts on all of the other elements of performance that come through the system. So you can see within there, and I'll just describe certain areas just for so we can just talk through them slightly, as our A&E position, although we've not routinely reported the 4-hour wait for the hospital for well over a year now, because we've been following the national metrics, continue to see an under performance in terms of our expected levels of attendance. So we've played that through in the report. But then you can see the impact, continued impact on areas like diagnostics, on cancer, and also on our elective care. So you can see that the elective care was absolutely coming back as per the national plan. So it was coming back in August, September, October and November. And although we're not reporting forward at the moment, I would suspect that will either hold or it'll start and dip back down as we're going through into that January period. So those acute indicators are really challenged at the moment in terms of where we're looking, really trying to prioritise our urgent treatments that we need to do on the elective in the elective world. Our 6-week wait diagnostic is not where it wants to be, not where anybody wants it to be, but it is in the pack with the national figures. So although none of this is nice reading in terms of what the expectations of Rotherham Place and where we'd all want to be, we are in that pack compared to nationally. And our mental health performance on our IAP services seem to be stacking up okay, but we are seeing an increase in activity now, although it's not in this report, but it's helpful context for governing body. Our IAP services are delivering well. We've got additional capacity, as we know, through our ESO, supporting through a digital platform. But we are seeing increases of presentation through our crisis services, and we continue to do work around that to support those people in crisis. So I think, again, Chair, you'll see the key bits by exception there within the reports. It hasn't really changed a great deal in terms of the commentary month on month at the moment. I think what we will continue to do as soon as we can get some headspace from the current wave 3 position in terms of responding to COVID, and the vaccination programme hopefully starts to kick through, we can then look at what does it look like to recover our system. Okay, I'll pause there. Happy to take any comments or questions.
Okay, any questions or comments from any of the board members? Okay, we'll move on then. Quality and patient engagement. Sue sent to apologise that Catherine is here in her place. Right.
Thank you. So good afternoon, everyone. If I can point you in the direction of enclosure 11. This patient safety and quality assurance report, I'll just choose a few areas, if that's okay, with Chair, and draw your attention to them. So firstly, with regard to healthcare associated infection in section 1, Ardash and Rotherham Hospice continue to report no cases for 2021. The CCG Infection Prevention and Control Lead continues to provide a raft of clinical expertise and support to colleagues, including to GP practices regarding the national guidance. As discussed by others previously, partnership working has been outstanding. It's been absolutely brilliant with regards to care homes and care home staff who've all been invited to training. These sessions will continue on a monthly basis going forward and have been extremely well received. We would also suggest that there continues to be some excellent collaborative work with the local authority, TRFT, and Public Health England, as well as the CCG. Of note, there's been 2 cases of TB identified. Case management and contact tracing has been implemented, and to date this continues to be very well managed. If we look at section 3, the serious incidents continue to be proactively managed with additional SI meetings in place to facilitate a prompt resolution and learning from these serious incidents and never events. Section 4, which is the safeguarding section, I'd particularly like to draw your attention to Safeguarding Awareness Week, which was held mid-November. a very different Safeguarding Awareness Week nationally for us all, but has provided for Rotherham in particular some excellent reach achieved into statutory and public, the public. Particular interest from me was to look at the video sessions which reached over 5,000 people, which gives safeguarding a really significant platform. Page 9 of this section 4, the report spotlighted an update on Rotherham Safeguarding Children Partnership. This coincides with it being 1 year on since we changed our statutory arrangements. It also coincides with some work from national government to look at safeguarding children arrangements and to make sure and assure ourselves and the public that children are being safeguarded. Section 6, the continuing healthcare section. The continuing healthcare team reintroduced all routine assessments from the 1st of September. They continue to work with the partner organisations to implement the necessary changes and processes that will deliver a discharge to assess model in accordance with national guidance. The CHC team, the CCG's continuing healthcare team works exceptionally well with the Acute Trust, the Mental Health Trust and the local authority to agree joint processes and the planned trajectory that will ensure that cases are all undertaken in the timeliest manner. If we look at section 18, the learning disability mortality reviews, fortnightly reporting continues with NHS England and improvements regarding process on all learning disability mortality reviews, notifications, and really delighted to say that the deadline of the 31st of December, we beat that by 4 weeks, making sure that our reports were all up to date, and notifications during November and December are on target to be completed within the 6-month time frame. And happy to take any questions on any of the other areas.
Okay, questions from anybody? Okay. I think one of the things this report highlights is the ongoing work that people are doing, the day jobs, as well as taking on stuff with COVID and continuing healthcare and infection control. The workload has not gone away, it's continued and has increased. It just demonstrates again the commitment of our workforce to go above and beyond what is normally expected over the last few months. So just again, the board's thanks to all these people who take on all this extra work and still doing the day job. Okay, moving on then, Catherine. Patient
I'm very happy to report on enclosure 12, or if Debbie would prefer, I don't mind, whichever.
I don't mind, Catherine. I'll do it if you want. Is that okay with you, Chair?
That's fine.
Okay, fine. There's an awful lot of work been going on, obviously, in the last few months, but I'll just summarise. It's enclosure 12. I'm sure you've all had a chance to read it, but there were like 4 sections to it. We had the reports being published from a wider South Yorkshire and Basset Law engagement activity that was actually undertaken at the beginning after the first wave of lockdown and sort of really around the June, July time. But that's now been published, that report. There were 7,000 people's information was gathered about their experience of the pandemic. And not unsurprisingly, anxiety, isolation, access to digital issues, and the delays with regards to information coming through, and then too much information, almost, conflicting messages. So those were some of the summaries of that findings. Obviously, this was relating to August, although it's only just been published. There will be a wealth more information, I'm sure, coming through in subsequent reports. Helen, our public and patient engagement officer, she's been very much staying in touch right across Rotherham with all sorts of different community groups, such as Kiverton. We've held all sorts of virtual PPG groups, and she's been very much in touch with the community groups and supporting those in their volunteering within their own communities. There's a big section about the flu vaccination, but I've spoken how that's sort of now rolled on into COVID-19 already this meeting. And just a really noteworthy, we have a national, every year we have a national assessment by NHSE regarding our public participation assessment, and delighted to report that we came out 13 out, I think it's 15 marks that that you can be awarded, and we came out as green, which fits in with obviously the fantastic CCG outstanding assessment that we've also had across the board. So that's about it really.
Okay, thank you, Debbie. Any questions or anything on that paper?
Okay, thank you.
Thank you, then. Ruth.
Moving on, thank you, Chair. Could I take items 13 and 14 together, please?
Yeah.
Okay, so the policy and the procedure, the Integrated Risk Management Framework, has been updated to take into account the changes in the organisation and also the changes in the GBAF. And these updates are tracked within the policy, so you can see them there. And the timescale document, which is at the front, has also been updated this year, so you've got that as well to track it through committees. As you were aware when you saw the GBAF at the development session in November, this has had a full redraft on the new template, and we've gone through a robust process with executive and members of OE to ensure that the 3 risk documents which form the operational part of the risk management framework cover the strategic and organisational risks that we were facing at the last OE meeting in December when these were last discussed. These have all been through AQUA, and the policy was approved by AQUA. I'm happy to take any questions.
Okay, John, do you want to just confirm what AQUA thought?
Yeah, I mean, we were clearly sort of like supportive of all the policies and papers here. It was quite an opportune, timely time to receive these, both at AQUA and here at Governing Body, in the context of the Head of Internal Audit opinion, because they will shortly be doing the stage 2 part of that opinion, and it's important for our overall year-end governance and annual report that the Head of Internal Audit opinion comes out okay. And I think there's nothing there's nothing here that would suggest there'd be any problems with that, really. I think I think that once what we've got here, this package is reviewed by Internal Audit, will be okay at stage 2. I think it's important that despite lockdown and despite the pressures, that we continue the process of good management of the risk management processes and the GBAF and the risk register as far as we're able.
Okay, thank you. Any questions about these? Comments? No? Okay, so we're asked to ratify the framework. Is everyone happy to ratify it? I see nodding heads. Okay. Anything else you need from us on those papers, Ruth?
Well, that's great, thank you, Chair.
Okay. Moving on then, AQUA subcommittee terms of reference.
So this is the annual review of the terms of reference, and it was taken into account in action from Internal Audit, which says that at the next review date, the AQUA terms of reference will be updated to make specific requirements, specific reference to obtaining and managing conflicts of interest. So we've updated it to do that. We've made a couple of other tweaks to it as well, as you would do when you do a review. And this has been approved by AQUA. John, I don't know whether you want to say anything further.
There's nothing really to add to that, Ruth, thanks. I mean, I think AQUA is recommending these small changes to Governing Body, and that Governing Body set these terms of reference for us to work to.
Okay. Any comments, questions? Okay, so we're happy to ratify this. Take silences. Well, I can't take silence because you're all on mute. I can see nodding heads and thumbs up. Okay. Next paper is Medicines Management Q2 report. Is Stuart coming, or is someone else taking this? Lindsay, on your mute.
Sorry, Chair. Stuart is coming. Yeah, I'm not sure what time, but he's definitely coming into Lindsay.
Definitely coming, but I didn't really know what time to give him because
I'll send him a text.
Right, okay, well, you better tell him to hurry up because we've got very little else on the agenda. Okay, now, Janet, you better just talk a little bit about the minutes from other meetings. We'll start with you, Janet. You've just got to expand the time while waiting for Stuart.
Thanks, Chair. These are the minutes from the ratified minutes from the Primary Care Committee meeting in November. So we've had another 2 meetings since then. I'm happy to take any questions if anybody's got any questions on it or any comments. And Stuart did present the Medicines Management Q2 report of the Primary Care Committee yesterday, but I'm hoping he gets here so that I don't have to fill for the report. But he did go to the Primary Care Committee, that report yesterday.
Well, we'll just be asking members of the Primary Care Committee to just present it then, because you understood it so well.
But I'm happy to take any questions, any comments on the minutes, if anyone's got any.
Okay, any questions? No. Aqua minutes, John?
Yes, Chairman. These are the minutes of our meetings in November and December. We've moved to a monthly cycle of meetings now. I don't think there's anything to escalate to governing body, but much of what we've been focusing on is on the agenda today. We've been looking at the financial performance and the financial forecasting. We've been looking at risk management and the GBAF processes. So our focus has really been on some of the items that we've already discussed on the agenda. So nothing particularly to escalate, but if there are any questions, I'll try to answer those.
Okay, any questions? Okay. Then it's up to you, Chris, to extend the meeting till.
So, in terms of the health executive group, the key thing, it's almost as if the integrating care was everything we were covering in the December meetings, but there's a recognition that COVID now has reached a point. So we've delayed integrating care for a few weeks. So we continue to cover COVID issues because they are so significant, and the ambition is to pick up the integrating care agenda in the second week in February. So that's where we've got to in terms of that meeting. I haven't really anything else to update apart from that, Chair.
I've just spotted an error. Leslie is still down as the Barnsley Accountable Officer. In November, I think you'd taken over then, hadn't you, Chris?
1st of September, yeah.
No, that makes just time for Stuart to arrive, so he's just joining now. Perfect. Welcome, Stuart.
Hello.
We are waiting for Medicines Management Q2 report.
Right, okay, so you should have the report in. Has everyone got access to the report? Have they, or
yeah,
do I need to share it?
I think everyone should have access to it.
Everyone has access to the report. Okay, so thanks, Richard. I'll briefly go through it then. So as of September 2020, 6 months into the financial year, our cost growth currently stands at 4.4%, which is below the prescribing cost growth of England, which is at 4.57, and below the average for the Yorkshire Humber area at 4.81. We're also below similar CCGs in our areas such as Barnsley, Doncaster and Wakefield. Our item growth, which is looking at the number of prescriptions that we've issued, is slightly above the England average. It's a minus figure at minus 1.34%, slightly above that for England at minus 1.41. But again, we've got a, it's difficult to say it's stronger when it's a negative. Our item growth is less than Barnsley, Wakefield and Doncaster, who are matched to it, but slightly above the average for England, but below the average for the region. It's proving to be quite challenging year early on in coming up with a forecast and looking at where cost growth and item growth have been due to the high variability between the months due to lockdown as a result of COVID. But that now seems to be settling to a little to some degree. and we're currently forecast to have an end of year cost growth if everything stays the same. And there is the issue of Brexit and what impact that will or will not have on supplies and availability of pharmaceuticals. We've got no information coming through at the moment apart from do not hoard, do not prescribe in advance, and everything will be fine. But if everything stays the same, we're looking at a cost growth at the end of year of 2.88%. This year's been equally difficult because of, again, a large number of NCSO issues. This is where no cheaper stock is obtainable. So these are drugs that are commonly used drugs, which are not available at the drug tariff price. As of up to September 2020, total excess cost compared to the same period last year was 933,000. 663,000 of that, or 71% of it, was due to NCSO issues. So that's not growth in drugs or not changing prescribing habits. That's actually just an increase in the unit cost of drugs not being available at drug tariff price. 66% of our cost growth is due to one drug, the antidepressant sertraline, which has not been available at drug tariff price. And the blue graph with the red line through it will show you the effect that's had on Rotherham. That's accounted for 439,000 of our increased costs to date, which is 66% of our cost growth. Sertraline is in all things being equal, it's the first line antidepressant as recommended by NICE. It's not a drug that you can switch away from very readily. The good news is that's now returned back to almost at drug tariff price. Those cost pressures are not going forward. It's probably hurt Rotherham more than some CCGs, as we have traditionally and still are a very high prescriber of antidepressant drugs, with the second highest prescribing rates in Yorkshire. But those issues now appear to have largely resolved. And again, if we carry on track, bearing in mind possible fluctuations in price and supply problems due to Brexit, we should be coming in at 2.88% cost growth at the end of the year, which is a fairly good position to be in. The table looking at practice cost growth shows a high degree of variation between practices in both item and cost growth. We're going to be exploring that with practices over the next 6 months, particularly those practices which are showing an item growth that's above that for the Rotherham average. It's a difficult year, but we have managed to launch 3 fairly exciting projects within the year and given the unusual ways that we're working. So we have revised our info-feeding pathway. So all children now that have suspected cow's milk protein allergy or problems with feeding are now referred in a very timely manner. Within a couple of days, get a dietetic referral and are seen by the dietitians. This was a way of actually managing the introduction. We, like a lot of CCGs and nationally, are seeing a big increase in the use of specialised formulary milks due to suspected cow's milk protein allergy. The evidence base would show that we can get these infants seen by a dietitian quickly and timely. Then the diagnosis, alternative diagnosis other than cow's protein milk allergy may be made, and alternative strategies can be put in place. We're probably, as is most of the country, overdiagnosing problems regarding cow's milk protein allergy. We've also, as I mentioned, we've got the second highest prescribing rate of antidepressants in Yorkshire number. We have had for a long time. Historically, we've always been there. We've now started doing some antidepressant medication reviews. This is a long piece of work that's come to fruition, in that we started off probably 2 years ago talking to patient participation groups around Rotherham and doing an extensive patient engagement exercise to ascertain what patients themselves felt about antidepressant medication. The learning from that we've taken forward. We're now we've got one of the team specifically working on this project 2 days a week. We're identifying patients who, in accordance with NICE guidance, are on an antidepressant. We can see no reason why they need to be on an antidepressant ongoing. They don't have extensive issues, and we're inviting those patients, and again, in accordance with NICE guidance, which shows it's very difficult to stop antidepressants, to come and talk to us, and if they wish to and they want to, review it and stop their medication, to work with us on how we can reduce the dose and maybe stopping it. Did not wish to demonize antidepressants. They're very, very useful drugs, but also they can have long-term side effects, and we don't need people on them who don't want to be on them. Rotherham's not historically managed diabetes particularly well. We've also got a project starting working with dietitians and the diabetic specialist nurses, working specifically with some practices to review patients who are on high doses of insulin and are still unable to obtain the targets around blood glucose monitoring. And that work's just about to start as well. So that's a brief summary of where we are up to Q2 of this financial year.
Okay, thank you, Stuart. Any questions for Stuart? Jeff?
I think again, it was just a comment because again, this, as Debbie said, had come to primary care yesterday as far as that. So again, I think before you came on, Stuart, sort of saying that trying to predict this is like being a 1950s weatherman of the last year, isn't it? Debbie had made a point about what was it worth looking at some of those figures in the bottom chart when it was like PCN wise. I think that may level sort of some things out, but it's something to look at. But I did make a point that I think one of the things in terms of the traction with this is that, and you can see that, but the additional role staffs with sort of pharmacy over the sort of coming year, I think most PCNs are going to take out a significant number of people in terms of prescribing. We could just look at that's repeat prescribing and EPS and tidying things up. But I think one of the issues before with this is there's loads of things we can look at, which is quality markers and things we should be doing. But it's having the time and the manpower and motivation to do that. We in practice have had an ACP pharmacist that's done some local work for us, sort of picking off the routine list, but also sort of doing some project work. The stuff that we're having to do for the structured medication reviews for people in nursing homes, and she's like took that and sort of 2 days done them all. And when we've ever projects for the stuff that's on the IF things in terms of prescribing things and also stuff in terms of prescribing incentive schemes, within a couple of days work, she's like took those lists and worked with them and done them. And I think even I think this was saying earlier with the flu vaccines, the experts with that are the nurses when we're dealing with asthma and COPD and diabetes, the sort of day-to-day stuff, the experts are the nurses. I'm not lumping everyone else into that. GPs were quite good at adding medications in, but we're not always good at stopping them. If you actually stick that with a pharmacist, that's like where they sort of work with. And when the PCNs have actually got those staff in place and then are being structured sort of within the networks to sort of look at those bodies of work, I'm sure we can again actually get much more traction. Again, if you asked us, I think this the prescribing scheme this year, I think is good that it's got out there and a lot of it's like stuff that we can sort of do, but in the middle of COVID and running around. But if you've got 2 pharmacists and they're on sort of this week doing sort of however many days work, that you pass that on to them, they haven't got that excuse that we have of saying, but we've got stuck with people ringing in and interruptions and district nurses. So I do feel prescribing in a sense when we get those bodies on the ground is something that we hopefully will see sort of more traction on.
I think going forward, Jeff, the increased role of pharmacists, well, I'm obviously going to say this in practice is I'm very supportive and very encouraged by that. And I think there's a lot of benefit that the pharmacists can bring to practice. I think the challenges for us are everybody's fishing from the same pond and trying to find staff that can actually do the work is improving, increasingly challenging, and perhaps for us as an organisation, we perhaps need to look at sort of nurturing, coaching, training some of these staff to fit into these roles. And also making, I mean, it is an attractive area. I've worked here long enough, but making Rotherham an attractive area compared to some other areas to come and work. And I think, looking at that kind of holistic sort of training and support to new pharmacists coming into practice could be an area that could make Rotherham look a little bit more attractive if we were offering more support, say, than other areas.
Yeah, I think it is hard work finding people, and definitely 100% it's having the right people as opposed to having.
Absolutely.
But I think so. There's a pinch there, but nonetheless, I think we're all looking to get some pharmacists in place, which compared to like 2 years ago when 99% of us had no pharmacists in place is sort of gonna sort of help. Yeah.
Thanks, John.
Stuart, we were talking earlier on the agenda on the finance report, about how the underspend on prescribing is making a good contribution to helping us deliver our financial targets this year. So that's good. But we didn't know if that was going to continue. And in your report, you talk about cost of item growth demonstrating high volatility. Do we understand what causes that volatility? You know, the difference in prescribing on a month-by-month basis.
It varies from a month to month. It can be simple things like how many dispensing days there are in a month, how many weekends there are in a month. This year it has been particularly difficult because of COVID. So we did see in the first beginning months of lockdown a huge increase in demand. And certainly, you know, we could see that patients, there was some panic in the situation, particularly around inhaled medication. We had some ridiculous growth rates on request of prescriptions for inhalers, which led almost to national shortages. And we also observed patients requesting medication they'd not had for months, for years in some cases, suddenly requesting it again. Also, a lot of our self-care agenda, which we've been very successful on over the past 2 years, a lot of that got reversed. That seems to have come back into self-care with patients again requesting medication on prescription. And to be fair to patients, you couldn't get paracetamol, you couldn't get vitamin D from the supermarkets. It just wasn't available. But it was available via the prescription route. So that caused us a bit of a hiatus for the first 3 months. Conversely, antibiotics, which we thought would actually go through the roof because people can't see their GP, were almost 25% down on antibiotic prescribing, which may be because people aren't mingling so much, or it may be the fact that because they're not seeing their GP, then they don't expect to go away with prescription. We need to investigate that a little bit further and look at some of the learning that we can take from that going forward. The cost pressures regarding NCSO, they are just completely random, and there's no warning or whenever they come in. I mean, there is some manipulation of the market. You know, pharmaceuticals are global commodities. And, you know, if the price is low in the UK, stock just doesn't come into the UK until the price rises. It's almost impossible for us to actually, you know, horizon scan and, predict that.
Okay, thanks. Simon.
Hi, Stuart. It was just a quick word about the difference between practices that you said of the cost growth. Have we had a chance to look at it and see how much that sertraline, were those practices using it more, or is it more of a chronic problem with those practices?
It's a bit of both. I mean, the data that we have around antidepressant prescribing is really interesting, and this is what we want to start discussing with practices, because the number of patients on antidepressants varies massively between practices, even practices in very similar geographical areas. So, you know, you can't really match antidepressant prescribing to any particular demographic. It does seem to be sort of the threshold to initiate an antidepressant is very much with the individual prescriber. So certainly sertraline would have affected some practices more than others, and not always the practices that you'd expect. So that is the job for the next couple of months, Simon, really is, and is discussing it next week in my team's meeting, is to actually drill down to some of this and work out what is driving some of the higher cost growth we're seeing in some practices, to get the detail on that. Certainly Broome Lane, Richards is excused because he did merge with Broome Valley, so that's why his cost growth has gone up, because he's a bigger practice than he used to be. And certainly with Woodstock Bower, that's falling out the system, but they switched systems, which means they kind of front loaded the back end of last year, did a lot of scripts in advance, which made them give a trough, which now looks like they've got a higher cost growth than they actually have. So but when you strip those things out, this is what we need to start looking at as to the variation there.
The only other thing I'd say is, because two of my practices are in there as a PCN, and we actually didn't have as many pharmacists at that time due to problems of recruitment, and might be really interested in looking at whether that made a difference or not.
So rest assured, we will. If you're on the list, if you're shaded in red or salmon, whatever colour you want to call it, well, you'll probably get some information from us as to why things are looking a bit hotter than the rest of the CCG.
That's it.
Okay. Any more questions, Stuart? Thank you for mentioning my practice, and the reason why my practice is where it is, Stuart, because I would have had to mention it otherwise.
Yeah, you've got to get out of jail free card this time, Richard.
Yeah. Hopefully people watching will still be watching next year to see the update and see whether we're further down the league. Right. Okay.
You could put a spin on that you're part of Broome Valley, Richard, who reduced by 98% though.
That's true.
That's true, yeah, it's true.
And doing all the bad maths, I was going to add the minus 98% to the 11.
Yeah, a little bit better then.
That's not how maths works. Anyway, right. Okay. Thanks very much, Stuart. For
no problem. Okay. Bye now.
Thanks. Okay. Just coming to the end of the meeting then. There's no any other urgent business that's been notified to me. I don't think there's anything new to escalate or any additional risk raised. Therefore, we need to consider the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, publicity which would be prejudicial to the public interest. And with that, we'll call an end to the public meeting. Thank you, anyone watching. Please remember you can submit questions, queries, statements relating to the agenda, and we will talk about at the start of the agenda at any time. Otherwise, the next public governing body will be on the 3rd of February, and the confidential governing body will start at 2:25 So I will see the governing body then. Okay.
Thank you.